Well, welcome everybody. I'm thrilled to have you all here. For those of you that I haven't met, I'm Jen Jelly. I'm the Executive Director of the Minnesota, North Dakota, South Dakota chapter of the ALS Association. And we're so excited to welcome you to our new office and the first of our Gayle Sit Memorial Summer Speaker Series events. And to those of you that are joining us via live stream, welcome. We're thrilled that you're here joining us in that capacity. So we moved into this space in February, and it is already changing the way that we serve the ALS community. Not only is this space accessible, but it's centrally located, and it's given us room to operate and engage with the ALS community. The room that we're in right now, this is our Connectivity Center, and it is part of a multi-year initiative to enhance our connection with those that we serve. So you may have noticed that this room is outfitted with a lot of technology, and that will allow us to do things like video conferencing, live streaming, demonstrations, webinars, all to support our core program and services, but allowing us to connect with people throughout our service area no matter where they live and no matter what their mobility may be. And that is really exciting. This space is also allowing us to bring people in, like with you here today. We've seen more traffic in our office in the last 4 months than ever before. And we are now hosting our support groups here, which allows individuals and families to engage with each other. And it allows us to have events like this and bring you all into our space. So thank you, and we're thrilled that you're here. So throughout this speaker series this summer, we'll be highlighting topics that are not only critical to the ALS community, but are the core of our mission. So coming up in July, we'll be focused on innovation in care. And in August, we'll be talking about advancements and opportunities within advocacy and public policy. So if you want more information on those dates, please check that out as you leave. Today, though, we're focused on ALS research, and specifically an area of research that there's a lot of excitement around, and that's gene therapy. So we have two speakers here today, Dr. Walk from the University of Minnesota and Mark Bierman, who has been participating in a clinical trial related to gene therapy. Before I introduce Dr. Walk, I do have just a couple of housekeeping items. One, please feel free to grab the giant pastry. If you need one in the middle of the presentation, bop on over, that's great, or fill your coffee. And if you need the restroom during your time here this morning, if you just want to head out the doors in the back, there's signage that will bring you around, and then we'll come back through that way too, so that it's easier for those live streaming with us today. But, one more thing about the bathrooms. When you do go to the restroom, if you just press the accessible paddle, the door will open. You don't need to worry about a code on the door. But now it's my pleasure to introduce you to Dr. David Walk. Dr. Walk is a professor and the head of the Neuromuscular Disease Division at the University of Minnesota. He's also the medical director of the University of Minnesota ALS Center and a member of our chapter's board of directors. So I'm pleased to welcome Dr. Walk.
Thank you.
Modulate my voice. I'm not too loud. Now I'm really nervous because I see that our clinical or research coordinator is here. Well, thank you for being here, and I'm going to tee up the presentation of the special guest star, Mark Bierman. But what I have decided to do is the following, and I'm going to kind of go through page by page. Mike, should the front lights be a little lower, or is this going to work? I don't know if that's an option. Does that work better? Yeah. Okay, great. So first I'm going to talk a bit about some challenges in ALS research. I think that's important for people to have a realistic understanding of some of the things we're struggling with to get to the next step. Then a little bit of an introduction to ALS genetics, high school biology basically. And then using that introduction, what are the potential genetic approaches to ALS therapy or ALS treatment? And I always like to throw in a little bit about current clinical research in our region. So I have some highlighted studies that are being done locally. So Imagine taking a 7-year-old to an art gallery and putting them in front of this painting and asking them, what do you see here? What's happening here? And she'd probably say, well, this guy looks important. Looks like they're heading from a bad place to a better place. Looks like he's telling the other ones what to do, and they're actually making it happen. There's a story there, right? And there's a kind of, without knowing US history, you can look at that and you say, I know what's going on here. I can put together a story, and there's only one story you could put together. Then you take her to this painting, and you say, what's happening here? And she'd say, well, let's see now. I see a part of a cow. I see a part of a horse. I see some faces. They don't look very happy. I see arms here, legs there. Looks like there's a bright light in the sky. But I'm not sure what's actually happening, And without understanding the history behind it, she might have difficulty putting it together. She'd identify correctly several things in the picture, but it doesn't tell a story. I'm going to show you a picture from a ALS research review article that's intended to try to tell people who don't know a lot about ALS and want to learn fast what's happening in ALS research. Okay? Now, which paintings does this look like, right? Does this look like Washington crossing the Delaware, or does this look like Guernica? I want to remind you all that with all of the advances, and there have been substantial advances in our understanding of ALS, we're still in a situation where we know a lot of things. We can identify, this is going on, and that's going on, and that's going on, and this is going on, and here are 6, 10, 15, 20 different things that we can see in this picture. But we still don't really have the story. There's not a universally agreed upon, this happens, then that happens, and then somebody develops the disease. And that's a problem still with ALS. And certainly there's progress and better understanding. But it's important to make the point that we still need a lot of basic science research to understand ALS better. People like myself, clinicians, people who work in the clinical environment and are involved in clinical research studies, sometimes designing clinical research studies, we can say, maybe we've got a drug that might target this problem or this problem. And maybe we can even be smart enough to say, we think this 5% of people living with ALS principally have a problem with this part of the cell. Let's take this drug, find those people, and test it out. And we have to do that until we have all the answers, because we can't wait and just leave all of our hunches on the table. We have to try them out. But until we get to a unified story that makes sense, it's going to be tough. And it may be that there are several stories, and I think you've all heard that. It may well be that 5% of people in an ALS clinic, have a problem with their mitochondria, and 10% have a problem with oxidative stress. And it might be that 30% have a problem with a single gene that if we could do something about, we could stop their ALS cold. So that's where we have to get. But those genes are a useful clue. So, outlining briefly some of the big challenges that I think are being recognized and to some extent addressed. I already covered this one. No known single cause. There may be a single cause, there may not. But unlike some other conditions, there's no known single cause, hence no single treatment target, except perhaps in some genetic forms. Obviously, I'm teeing you up for Mark. Difficult to tell what's working. If you do a 6-month clinical trial, and the only way you can tell if your treatment is working is by asking somebody if they're walking worse or better, or testing their arm strength, you're going to miss a lot. And you may not know, you're testing the final outcome, which is critically important, but you might miss the fact that that treatment is actually doing something biochemically that it's supposed to do, or not. And you've heard a lot about biomarkers, and that's what those are. Those are measures that we can use to figure out, is something working? Is it reaching the target? Is it reaching the part of the cell it's supposed to reach? Is it having an effect there? Is somebody getting worse or better, even though we can't tell just by asking them? Is there some blood test or urine test or MRI scan that's going to tell us that faster? Is there somebody who's a better candidate for this treatment versus that treatment? Those are the things that we need. There's progress on that. There's a lot that's being done to try to find those biomarkers. But that's been a holdup with ALS clinical research. I think many of you have heard about this issue, clinical trial eligibility, narrow versus broad. So if you have a treatment that we're all excited about and everybody wants to be in a clinical trial to see if it helps them, and you say, everybody come on in, we're going to enroll you in this clinical trial. And you've got 400 people living with ALS in the study, and 100 of them are going to be worse in a month. 80 of them are going to be no different 3 months from now. 40 of them don't really have ALS. Somebody made a mistake in the diagnosis. You know, it's going to be pretty hard to tell if that stuff works if you're putting all of the slow progressors in the placebo group and all the fast progressors in the treatment group, or vice versa. It's going to be hard to tell. If, on the other hand, you say, we only want you and you and you, but not you and not you, because you three happen to have the condition for less than 6 months or a year or 2 years, your breathing is normal, you're independent in your activities, but you've proven to us that you are getting worse at a particular rate, and we're quite confident you have ALS, we want to just study you because we think that will give us a better chance of proving that this works or doesn't. That's great. You've got a better chance of proving that it works or doesn't. Well, what happens when you prove that it works? That's wonderful, right? But then is it going to help her or him, right? We don't know. We haven't tested them. And that's the real life situation that came up with the Edaravone or Radicava. They did a clinical trial, didn't seem to work in ALS, but they thought, oh, maybe some people it does. And they narrowed the criteria, did another trial, and bingo, it worked. Now we've got an approved treatment for ALS that costs about $150,000 a year and that requires numerous intravenous treatments, sometimes going to a treatment center. And we're saying to people, well, we're not sure if it works for you or not. Do you want to try it? Well, that's great that we have that option. But this is the generalizability problem. And there are efforts to get around that. So for example, you can do a trial like the second one they did, but also if you have the resources and the people, allow you and you and you to also try the drug. Gives the manufacturer an way of finding out, number one, how safe is it in a larger group? And maybe you can get a little bit more information. So there are ways to get around that, or expanded access is a way to get around that. But that's been a big problem, a big challenge in ALS research. And finally, inefficiencies created by multiple independent trials. We test 6 different drugs in the region at the same time in 6 different facilities or 4 different facilities with 6 different budgets, you know, each with its own coordinator, each with its own set of blood tests, right? So how do we get around that? Many of you have heard probably about the platform trial that's been designed, and it will be starting up hopefully within the next few months, in which basically it's treatment agnostic. You've got the same protocol, and you know, Biogen and I don't know, come up with a name of another pharma company. 3 or 4 different companies can say, we want to test our drug on that platform, and you say, great. 6 months or a year from now, one of them seems to be working, they can move on to a better, larger trial. One of them doesn't, you can drop it off. You can bring in another drug. It's the same study. Certain differences, I'm sure, between different drugs. One of them might want to test something else in addition. But that way you save a lot of money, a lot of time, better throughput. So these are solutions, but these are also some of the biggest problems we've had beyond not exactly knowing what causes ALS. Some of the biggest problems we've had in trying to figure out what works and what doesn't. Okay, let's get to the genetics piece. So if you went to high school anytime after the early 60s, you had to pass a test with this on it. I'm sure you all remember, but this is the kind of the simplified version that we got back in the last century when I went to school. It's way more complicated now. But basically the simplified version, as you know, is that DNA is in the nucleus of the cell. It's transcribed into RNA, which then gets out of the cell, and it's got these little ribosomes and things that allow you to make proteins, which are the building blocks of our bodies based upon the code embedded in the DNA and the RNA. So think of the DNA as computer code. Think of the RNA and the ribosomes and all of that stuff as the user interface, because most of us can't read the code. And that user interface is on the factory floor, making the parts. okay? Proteins are the parts. So think of people as widgets, and proteins as the individual component parts of those widgets, right? And so if you're running a widget factory, you've got to have somebody writing the computer code for how to make the parts, and then you've got to have your supervisors and managers and technicians on the factory floor be able to understand what exactly to do. That's where you have the user interface, you know, the operating system and the computers and the bells and whistles. And then those folks are running the robots that are actually making the parts that are going into the widgets. Okay, so think of us as the widgets and the proteins as the parts. DNA is the code and the RNA is the user interface. So in ALS, we now know that in certain cases, part of the code comes up with something that's going to leave those parts wearing out faster than they should, right? And we know that maybe 10, 15% of people living with ALS, we can identify some part of that computer code that's going to result in parts that wear out too fast. Okay? I keep going backwards. So the next concept is penetrance. I want to just introduce this concept because it's pretty important. So the computer code problem, or the abnormal DNA, for example, that causes Duchenne muscular dystrophy, A, top left there, if you are male and you inherit that, you have a 100% chance of developing muscular dystrophy. If you are female and you inherit that, you probably won't. So the little gray people here are fine. The red people have the problem. If you're female and you inherit that, chances are you'll be fine. You might have some problems. Those are the pink people, right? You might have some muscle cramps or a little bit of muscle weakness, not life-threatening. Maybe there's a tiny chance that for some unusual reason, you'll actually get muscular dystrophy, okay? I'll use this example, which is relevant here, C9orf72. That's the most common genetic cause of ALS. So you're born with it, if you have that, right? But even at age 60, you've only got a 50% chance of having a problem. By the time you get into your 80s, you've got a much higher chance. But the penetrance is, at that particular age, what we would say it's 50% penetrance, okay? So the point is, there are lots of reasons why a problem in the code may or may not actually lead to the condition. And it varies depending upon the gene. So let's take it a little further. That's something called a susceptibility gene that increases the chance you might have a gene, have a condition, right? And all of us have increased susceptibility or decreased susceptibility to coronary artery disease or diabetes or breast cancer. So for example, there's a certain abnormality or change in the ataxin-2 gene, which is known for causing ataxia. Eva knows all about the work that's done at the University in ataxia. But if you get a mild problem with the ataxin-2 gene, you get a tripling of your odds ratio of developing ALS. Okay? Now, does that mean it causes ALS? I don't know. Is it a susceptibility gene? Does it just increase your risk? You can see that there's kind of a spectrum here, right, between a change in a gene that makes you more likely to develop a certain problem versus something that will cause that problem. There are even modifier genes. They don't cause the condition, but if you happen to have it, it's going to make it much more serious or much less serious. So here's a schematic illustration of that with some real genes listed. And we're going to talk about ALS here, because that's what we're talking about here. I'll get to that. But these are some of the genes in which abnormalities or changes can be associated with ALS. So, high penetrance. Remember, that means everybody gets it. SOD1 changes, specific mutations in the SOD1 gene are very, very, very likely to lead to ALS if somebody has that change in the gene. Highly penetrant, no matter what else happens to them in their life. C9 I already told you about, 50% penetrant at age 60. This particular picture says 100 plus minor genes. Well, I guess they're not that minor if that's the one thing that tripped you over to getting ALS. But the point is, those, you could say, well, maybe those are susceptibility. Makes it somewhat more likely, but not probable, right? So there's variation in the penetrance. Down here, you might say, well, Mr. Jones, you have ALS, we don't know why, but it could be polygenic, meaning that you might have 15 different genes that are just slightly off, not enough that it's going to, be obvious or one of the common ones, but could be contributing to your disease. Or you could say, Mr. Jones, your SOD1 mutation caused your ALS. And of course, in that case, you could say, well, maybe we can do something about that mutation. The other curious thing is, as many of you are aware, some of these genes can also cause dementia, frontotemporal dementia, FTD down here. In the same family, one person could develop dementia, another person could develop ALS. Different conversation, but those parts of the brain are actually closely related. They both developed super fast when we went from, not very smart rodents to really smart humans. Maybe there's a reason. Maybe they developed a little too fast. That's one theory. But regardless, not only can either one or several genes contribute to ALS, but one gene could contribute to different neurological problems. Okay. So this is why this is exciting, because when we know that a gene is relevant, maybe there's some things we can do now. So for example, tiny pictures, but immune reduction of proteins. Here's the RNA, right? That's the user interface. Here are the proteins. Those are the widget parts. You could just use immunology to tell the folks on the factory floor, well, we know some of those widget parts are going to be defective. Just go through them all and remove some of them, the ones that are defective. Just take them out. Or you're going to have 400 of this widget part and you only need 200, so just get rid of half of them. That's one way of trying to change the consequence of a genetic problem. By the time I'm done, I'll know which way to turn this wheel. You could target the RNA. You could say, well, it's a problem in the code. We don't have a coder around. But we can go to that computer and just kind of type in, just when this happens, we know it's wrong, just ignore it, And that way we won't get the defective widget parts. You could, maybe you do have a coder around. And you can say, well, we can't change the code, but we're going to write some more code that says, when you get to this little sequence of instructions, just ignore them. Okay? And that's what that illustrates in the kind of the real life example. Or you could actually change the code, which is what gene editing would do. So immune reduction of proteins, RNA ablation, small molecules interfering with transcription, and targeted changes in the DNA are all real ways that we can now potentially alter the problem that leads us with defective widget parts, which is pretty exciting. And it's a real thing now. So I put together this list. These are all within the past 2 years, okay? And this is just in our field, in nerve and muscle disorders. So SMA, and some of you heard about this, spinal muscular atrophy is a motor neuron disease like ALS. It causes progressive weakness. Unlike ALS, the most common form is in infancy. Shortly after birth, it becomes evident, and these babies die as babies. There are now 2 approved gene therapies. And you can go online and see videos of 5-year-olds walking around, happily playing. Not perfect, although the second therapy might be pretty darn close to perfect, because it's a single intravenous infusion, just approved by the FDA, saving lives. 2 treatments for a neuropathy or nerve disease caused by familial amyloidosis, again, a genetic condition. We now have approved therapies that will improve people's nerve function by altering the abnormal genetic code. And in ALS, the first gene that was shown to be abnormal in some people with ALS was SOD1, the one that causes the largest proportion of inherited or genetic ALS is C9. And we're now well on our way with a phase 3 trial of a treatment for SOD1 ALS. and in phase 2 for C9 ALS. These are antisense oligonucleotides, so it's the first on that previous screen, the kind of farthest left approach, where you're kind of interfering with the user interface so that it's not making too much of a protein that's causing a problem in the motor neurons. So with that, Mark has kindly agreed to talk to us a little bit about his experience because, right, this is now open access. I can say it, that Mark has SOD1 related ALS and has been receiving this treatment in the clinical trial that I mentioned.
Wanted to make sure I didn't drink out of your water glass.
That's all right.
Yeah, I'll sit on there and I'll just use this if that's okay.
Yeah, that's fine.
All right. Yeah, can I use that for my notes?
You're my indulgent.
So look out. Thanks for having me here. I had kind of a crazy day yesterday, so I had to jot down some notes. So if I skip around a little bit, I do apologize for that, but it was nice talking to a few people beforehand, and I know quite a few of you have connections to ALS, and maybe something I'll say today will give you some hope or some promise, but if you're here just because you want to learn more and just be part of it, then and you don't have any direct connection to ALS, then God bless you for being here, because that means you care. Am I loud enough? Is this okay? All right. You know, the whole process started when Dr. Wacht asked me to take a genetic test, and yeah, there's some issues with that, and I was apprehensive about it, and he kept encouraging me to do it, and there was a deadline by the end of the year for some financial incentive to have it done, and so I finally agreed to do it, and then a couple of minutes later, when I actually got the results, we were both somewhat surprised by it that I did have the SOD1 mutation. And with 2 children, that kind of motivated me to try to do the next thing, you know. And when I was first diagnosed, I was totally devastated and didn't know what I was going to do. And, you know, life became difficult for us, and sports and work and just daily routines became difficult. But once I got through that and I got beyond that, not wanting to meet my fate. In fact, people from the ALS office would show up at the clinic, and I didn't want to meet with them because I didn't want to know what my fate was going to be like down the road. And the reason I'm bringing that up is because I think everybody processes this information in a different way when they're first diagnosed. And I think you have to respect that and let people deal with it on their own in their own way, because it's very important for that. But the long and short story of that is that now all of a sudden I became eligible for studies. And before that, and through all of the advocacy trips I made to Washington, D.C., and all the research sessions like this, and every time we went to the clinic and we talked to Dr. Wacht and all the specialists, our impression and our thought was, I want to get into a clinical trial, because if I get into a clinical trial, I'm going to be cured, and I'm going to be the first one cured. And we were just set on getting into a clinical trial. Well, it never happened, and we always kept running into, you know, like Dr. Wacht said, different roadblocks and restrictions, and didn't know why. But then going through the advocacy and learning more about it, learning more about research, we realized that, you know, there's reasons why research has to be targeted to make sure it makes sense down the road. And we got to the point where we said, okay, if we do get in a clinical trial, we want to make sure it's for the right reason. And the right reason was basically to help those that are going to be diagnosed behind us. And it may or may not help us, but I think we got to the point where we really felt like if it was going to make a difference, we wanted to do it. Well, in this SOD1 trial, I think I was always kind of a tough guy anyway, but we read about it and I thought, ooh, this is going to be tough, because there's a lot of lumbar and punctures and injections, you know, spinal taps. And I've had a number of those, or I had a number of those before that, and those aren't fun. But in the back of my mind, I thought, you know, I can do that, and I will do that. And then I also thought, heck, I bet a lot of people are looking at going, I don't want to do that. I just want to take a pill or something and be done with it, and I thought my chances were going to be pretty good at getting into the trial. Well, I didn't get in the first round, and the doctor actually from California called me and said, look, we know that you're progressing more slowly, and we need, this is a long trial. This could last for 4 or 5 years, so we need to make sure people are going to be around for 4 or 5 years. And I said, okay, well, it looks like, I'm progressing slowly, so we could get into it. And then lo and behold, we got into the last cohort, which was the heaviest dosage. And I think I've made 22 or 23 or something like that trips to San Diego since last May. And for lumbar injections primarily, and for follow-ups and whatever. And there was some big news releases on it, and you can read about it if you have questions on it, let me know. But like Dr. Walk said, it is getting into phase 3. And I just signed the consent for that, so it looks like I'll be on a schedule now for once every 4th Monday, I fly, once every 4th weekend I'll be out in San Diego for a Monday injection, basically. And what I learned about that is that, first of all, I wore this today because my wife said, why can't you wear a coat or a tie? I said, because this is how I go to a clinical trial. She said, you're crazy. And I said, well, no, this is what I wear. And I said, I've learned that when you travel a lot, you gotta refine that. So that was probably the first thing I learned in that. So I wear light tennis shoes. I wear zip-off pants. My kids hate them. And I always wear a shirt that, that I can wear multiple times, And I bring a little bottle of detergent, which is kind of funny because my kids give me a hard time about that. But in any event, when you're at the trial, going through all the travel was kind of the tough part. But the trial itself is so professionally done, and it is. I think it's because it's so consistent, and the researchers are so professional, and everything's so consistent. And you have to be ready for that because it changes your life. And you commit to this thing, and they keep reminding me every time, Mark, I know you like to do other things, but you got to make sure you're safe and you can't fall because we need you to complete the trial. Because if you have, 10 people in a trial, in a cohort, and 3 of them don't make it to the end, and 2 of them are on a placebo, well, that makes it pretty difficult to get good quality data. So every time I go out there, I get reminded about how important it is to be safe. And my wife reminded me this morning when we got up, and she said, remember, your trial kind of becomes your job, because you're committed to it, and you got to make sure you're willing to do your part. And you do feel like you're a team member when you're out there. And some of the benefits are that the information that is given to you, or different tests that are given you, remember those, and they can bring them back, and we can talk to your own doctor about it when you get back to Minnesota. So there's a number of advantages for that. But I think the whole thing kind of came full circle when we were in DC about 2 weeks ago. And the C9 gene is also started I'm at University of California, San Diego, UCSD. And they also are starting the C9 clinical trial. And we met a lady, and she was like I would have been, when I was first diagnosed. And she was really excited about and she was recently diagnosed, excited about this new trial for the C9, and she had the genetics test, but she did not want to get the placebo. And again, I respect her for that. I didn't want the placebo up front, and when we left there, Linda and I talked about it, and we said, maybe she's just not ready for it, because if you do get into a clinical trial, I think the main thing is that you're going into it for the right reason, and that's not for your benefit, but you really have to believe it's going to be for the benefit of everybody behind you that may get diagnosed. And we said, we feel for her, and she was adamant about it. No, I just can't. I'm not going to do it if I have to do the placebo. I don't want any chance of that. Well, we both said, she's just not ready yet for the clinical trial. So I think I would encourage everybody that, if you're thinking about a clinical trial, or if you have a loved one that's thinking about a clinical trial, hey, the placebo is a big part of it too. And remember that, the people that are in the trial are probably going to miss out on the long-term benefits of it, but everybody is going to be helping the cause, and that's the big message that I wanted to deliver on that. And the last benefit I really received again. And this is just my opinion on it. Everybody's different on it. But, you know, when you're diagnosed and you have to give up your life basically and your work and your sports and everything else you love to do, you kind of lose the purpose in your life, which makes you get up every morning. You got to go to work. If you're in research, you're in fundraising, and you're working for the association. You're retired. Maybe your son, I talked to somebody in the crowd today, that your son is diagnosed. Your purpose is really to try to make his life better and do what you can for him. But you have a purpose in life. Well, when you're first diagnosed and you lose that purpose, it makes it difficult. For me, it was processing it. I got involved with the ALS Association. I did fundraising. I did advocacy work. But something was missing, and the piece was the research. And this kind of completed my purpose in life, and it gave me some real reasons to get up every morning and to keep moving. So, again, I'm going to look through a couple of the notes and see if I missed anything that I wanted to bring up today. I'd be more than willing to answer any of the questions you've got. I mean, it's a job. Clinical trials are a job. They're not fun and they're not easy, but when you leave, you do get a sense of accomplishment too from being involved with the clinical trial. And I don't know, it's a double blind, so I have no idea if I was given the placebo or not. I'm now into phase 2, and I just consented to phase 3. My phase 2 will end, I think, in about, I'm only in the first year of phase 2, so then bottom line, it'll go for 3.5 years yet. So I got 2 years of phase 3. So this is a long-term commitment for it. But hey, it's a pleasure to be here. And if anybody has any questions about it, today or anytime, you can always feel free to call me or call the association. They know how to get a hold of me. So, any questions from you, Doctor?
Beautifully done. Thank you.
Thank you.
We have time for questions for either Mark or Dr. Watt.
I have a question about the zip-up pants, but
Oh yeah. Okay. Not a testimony, but REI had some really good ones. They don't make them anymore. So, but I do have 2. I got the Patagonias.
I guess for either one of you, how long before you have insight for something that goes on for another 3.5 years, insights or into potential outcomes? You see that throughout the trial, or is it really at the end that analysis happens?
Well, if you're right, at times I feel different. I don't know if that's an outcome or not. Some things still happen to me. Sometimes I feel like I have more energy, but don't tell Dr. Walk this, but I fell yesterday. But but it was an easy fall, but it was one where I have too many things on my mind, with ALS. If his physical therapist gave me the best advice she ever gave to anybody with ALS. She said, if I'm going to walk to my next patient's room, I'm going to think about 4 different things on the way over there. And she rattled them off. And she said, what are you going to think about when you go back to the waiting lobby? I said, don't fall. She said, exactly. You need to make sure you only have walking on your mind when you're walking. And yesterday, we had a busy day with my wife. She's got some health stuff going on too, but I had about 6 things on my mind. And sure enough, but luckily it was right by the post, by my stairway, and I kind of fell down. But so bottom line is I do feel better, but you don't know if that's what the reason is for that. But then you have to be cognizant of, hey, I still have ALS. I can still fall. I got to be careful. And then I go right back into what my researcher told me. He says, Mark, we need you safe. You got to make sure you're using this at all time and make sure you don't get hurt. Because if you do fall, and you get hurt and you have to be hospitalized, that has to go back, it has to be reported, and it creates problems. So,
well, actually, I want you to say for you. By the way, that matters. And you were being cautious, but the kind of preliminary data that were released. So basically what pharma will typically do is they will often report interim results. So for example, in the study that Mark's in, interim results from phase 2 were reported, and there did seem to be a substantial slowing of progression. Again, it's phase 2. It's not enough to convince the FDA. But one of the things they're now doing in phase 3 is, I think they are kind of aggressively going after the particular SOD1 mutations that result in rapidly progressive disease. Because if there is some signal of benefit, they want to get it directly to the people who are losing function fastest. So that's what we'll often get. Now, any clinical trial looking at a novel intervention is going to have a DSMB, Data Safety and Monitoring Board. And basically what they are is a group of individuals who are not participating in the trial. They're not investigators. They're independent. And they're given interim data along the way. So let's say 6 months into it or a year into it if it's a 2-year trial, for example. And there are stopping rules that are defined in advance. So if they see evidence that reaches a certain level, predetermined level, that this is either not working, is causing problems, is dangerous, or is unequivocally beneficial. If at 6 months you can see it's working so well that it's almost impossible for the next 6 months to prove otherwise, they can stop the study, okay? And then say, move on to phase 3 or go for FDA approval because this clearly is working, or we have to stop because it's clearly not working. So there are ways of getting information along the way, but if there's still, even in a situation like this, so this is a situation where there's very encouraging preliminary data, but there's still less than complete certainty. And if there's less than complete certainty, they keep going and they try to get people who might benefit the most enrolled. And then again, those are circumstances where sometimes expanded access programs can be helpful. So if somebody isn't a candidate, but has rapidly progressive disease and might benefit, there might be an expanded access program where they can get the treatment outside of the study until a definitive decision is made. The other thing about the placebo issue, which you know, but I want to highlight, is there are a couple of ways about getting around that concern. First, I tell people something similar to what you say. I say, we've had trials where the treatment, so to speak, I try to avoid using that word because it's not a treatment until it's proven, but where the investigational product made people worse. So you have to understand that this is courageous volunteerism on your part. It's not necessarily a fast track to a cure. Second, many clinical trials, platform trials are a good example of that, will have a 1-to-2 or 1-to-4 or 1-to-6 randomization. So, for example, in the studies that Biogen is doing with gene therapy, they've got multiple ascending doses. So you could be getting placebo, 20 milligrams, 40 milligrams, 60 milligrams, 100 milligrams. So you end up with like a 1 in 6 chance of getting placebo, not a 1 in 2. Or the platform trial is going to have 4 drugs all sharing the same placebo group. So there's a 1 in 5 chance of being in the placebo group. Finally, there's the open label extension, whereby if you're in a clinical trial and it's important to you not only to participate in research for the greater good of getting answers faster, but also because you want to see if maybe you can get an opportunity to really try that treatment, then after the 6-month or 12-month study, the sponsor will say, we'll let everybody who participated in this study get the actual treatment, no placebo, for another X period of time, 6 months, 12 months, or sometimes they'll say until either it's FDA approved and you can get it commercially, or until it's proven to not be beneficial. And Valerie, you've been, we've got an open label extension for a CMT drug that we think works, and the drug company is trying to get the FDA to approve it, but until it's approved, the people who are in the study are all getting it now after the study ended. So, that's a good question.
Someone from the live stream has a question for you, Mark, about travel and lodging during clinical trials. Is that something that's covered in part, or covered fully, or is that something that you want to know for?
Question. It is. It's covered in part. There's, I'm sure every sponsor like Biogen has their own criteria, but they cover travel expenses up to a certain dollar amount per item, whether it's lodging or transportation or food and whatever. And so they don't cover tips, and they don't cover alcohol. But those are, and obviously some things that you will, pay for yourself. But a good portion of it for my trial is covered by the sponsor. Yes.
What does a local chapter do for you personally?
Oh, you know, I once thought about this, asked a question, but it's like the local chapter of the ALS Association is like a warm blanket on a cold winter night. I mean, the information that can be given to you, the resources, this chair actually came, this walker came from the ALS Association. I had another one exactly like that. I loved it, but it was falling apart, and I got one, you know. But so they do so much in that regard to take care of the needs, physical needs for me, and the dollars that go into research. And we feel so compelled to try to give back too. And fishing in the walleye tournament is I'm passionate about fishing, and so we try to give back in that way too, because we know that money can be used then to help other people out in that regard. And yeah, it's a great research. I just about completed the speech generating program, where it takes about 6 hours of just reading words, so that they get to the point where my voice won't work anymore. Like, I think it's starting to fade a little bit now, but then my voice will be able to use to allow me to communicate with people. So, great question.
I should add also that the ALS Association is also funding our research. We've had 2 studies here in Minnesota that have been funded by the association, and that's been very valuable. That's the good ideas don't make it to federal funding or industry funding until they've all been vetted, in smaller studies, and that's where foundation funding can be critically important.
And in my particular study, if you want to see more about it, you can actually go to the ALS Association, National Association blog. And there was a blog in December of 18, right when I was starting phase 2. It was pretty exciting for us. But it tells more about my trial, but also it says that the ALS Association was one of the first investors in Dr. Cleveland's research for this Antisense Technology that's taking place. And then the different pharmaceutical companies can use that technology, but Biogen's using the ASO, Antisense Technology. One of the notes I had down in there, I didn't mention it before, but I'm glad you brought it up, was that, I'm not a doctor. I went in the garbage and grabbed my daughter's biology book before she was throwing it out after she graduated from the U. So I started reading through it, but I'll never be a doctor. And I get frustrated at times when I don't understand everything, but I realize that I can't understand everything. I have to do what I do and rely on professionals like that. But Antisense, maybe you could explain Antisense Technology, what that really does and why that's so important in genetic therapy.
Right, so there was one of the slides on the right there, on the left. But it's basically creating a little piece of typically RNA that is going to capture and thereby capture the part of the code that's causing the problem. So it will belong onto it. And by so doing, either prevent it from being read out to make a protein, or it might actually target it for destruction. And so it's called antisense because it's the sense strand. I mean, DNA, again, is a bunch of letters. You can read a bunch of letters in either direction, right? If you're reading in English, you're going to be reading from left to right for the sense, and if you're reading English from right to left, or if you're reading Hebrew from left to right, you get antisense. You get the opposite of what you're supposed to get. So that's why it's called antisense. It's the opposite of the sense, so it will capture that strand that you're trying to suppress or destroy.
Yes.
So I think this may be for Dr. Block, but so with the gene therapy moving forward and the clinical trials, et cetera, how does the future look for doing gene testing prior to diagnosis, or what would something like that potentially look like? Okay.
Go ahead.
So that's a really, really important question. I think your question was, what about gene therapy before diagnosis or during the Are you saying before any symptoms, pre-symptomatic,
Yeah,
or?
what what would the future look like for like maybe a preventative or a proactive or,
Right.
you know, how do we get to it before somebody maybe develops symptoms?
That's a huge question. I think it's an open question. So for things like SMA, for example, which is a devastating fatal disease of infants that can be treated, the approach which was advocated for is to do that routinely as part of screening at birth, right? So there's now a kind of a list of medication, a list of conditions that grows as treatments develop, where every baby is going to have a blood spot checked for one of these 10, 20, 30, I don't know what it's up to now, right, conditions, because we know if they have it, we can treat it now, and it's going to be devastating if we miss it. In the context of ALS, it's appropriate if there's a family history, right, it will be appropriate, I should say, to do pre-symptomatic testing if we have effective therapies, but then the question will become, when do you apply that therapy, right? Do you take, you know, again, if there's a 50% penetrance at age 60 and people are healthy and they're living, you know, 80 years, maybe if there's an acceptably safe treatment, maybe it would be appropriate to treat pre-symptomatically. If there's a 10% penetrance and there are some off-target effects, meaning some side effects of the genetic therapy, you might want to wait until somebody develops symptoms. I don't think we have all the answers to that yet. But it's an obvious and important and good follow-on question.
How might this gene therapy help those who have non-familial ALS?
Great question, thank you. So again, I think that goes back to the question of other genes that might not be the kind of the major ones that can in and of themselves or have a very high penetrance, or modifier genes. So for example, again, I'll use the example of CMT, which is an inherited neuropathy, where this has already happened, not the therapy, but the recognition of a modifier gene of the most common cause of inherited neuropathy, which, if changed, makes it either very severe or relatively mild. So if you don't have a gene therapy for that gene yet, but you have one for the modifier genes, or let's say we have a modifier gene that is important for everybody with ALS, again, even if it's not inherited, we can test those people then, right? We can test what we call sporadic ALS patients and say, okay, you don't have a familial form, a genetic form like Mark does, but we have this particular gene. We know that if you have type A, it's going to be a fast progressing ALS. If you have type B, it'll be slow progressing. You've got type A, we can target that and turn your condition into a much more slowly progressing disorder. Finally, if we find certain ways to improve or change proteins, that's a traditional drug that would alter a part of the cell, the way it functions, well, we could just give that traditional drug, or if we don't have a drug, but we have a way of targeting the gene that makes the protein that is responsible for that part of the disease, you might actually be able to upregulate or downregulate certain genes and hence certain proteins that could change the disease. So in other words, we could arguably, even if you don't have a genetic form, if we figure out, if we go from Guernica to crossing the Delaware and we know that these are 5 or 6 steps that make ALS worse, you could modify that step not by giving a drug to change the way the protein works, but by giving genetic therapy that changes the way those proteins are made in the first place. So there are lots of ways you could imagine that being the case. And so one pharmaceutical company is developing another way of treating SOD1, and they're making the claim that SOD1 function might be important in everybody in ALS, even if they don't have a mutation like Mark does. Now, I don't know if they're right or not, but what they're doing is they're taking some evidence, a little bit of evidence that maybe if we modified SOD1 in everybody, it would make a difference. So there are some real opportunities here. And it may be that 20 years from now, people will be going to their doctor and not asking about the side effects of this traditional medication, but what are the off-target effects of this genetic therapy before I sign on. So it's a whole new world that we're entering. The difficulty, though, is, and I want to say this because I think it's a troubling reality. It's very hard to have this conversation when we're just on the cusp of it. And still, to be clear and to be honest and to be frank, people are dying of things that we're saying with enthusiasm we might have a really, really effective treatment did 6 months, a year, or 5 years. It's really hard kind of being in that period of time. Obviously, I want to kind of, when you have that conversation, you have to also be cognizant of the difficulty of hearing it when you feel like people are saying we're close, but we're not there yet. And here I am, getting weaker. So.
Excellent. Well, thank you so much to both of you. Can we get
There you go.
All right, I'm no longer connected to you. We're good. Well, thank you so much both to Dr. Walk and to Mark for sharing that. I know I learned a lot today. And thank you all again for being here. It is not a coincidence that we have seen so much progress in the last 5 years, because this year is the 5-year anniversary of the Ice Bucket Challenge. And we've seen a lot of progress because of that, and it's because of the funding. And we want to continue to fund this type of research to get us closer and closer to having less difficult conversations with the people that we serve about what's available. So we'd like to invite you to be part of that acceleration of research by making a gift to Research Today. Ryan and Mike will be handing out donation cards if you should so choose. For those of us joining us via live stream, there is a donate button on the YouTube channel that you can go to. I do want to tell you that your gifts to research have the opportunity to be matched today, thanks to a very generous commitment from Christy and Larry Waite, who are with us here today. Every new or increased donation to research will be matched dollar for dollar up to $10,000. So what that means is if you're new to giving to ALS research, 100% of your gift will be matched. If you have previously given to research, first of all, thank you. And second of all, any increase over last year's gift will be matched. And every dollar that you choose to give today will go directly into our global research program that is funding exciting things that are going to get us closer to those meaningful treatments and a cure. So thank you again so much for joining us today. And if you'd like to join us again in July and August, please let us know on your way out. And as you fill out your forms, you can give it to any of us staff with the fancy name tags. We'll take that. But thank you so much for being a part of our ALS community and being part of bringing us closer to our vision of a world without ALS. Thank you again and have a great day.